Good morning, everybody. This is Malik Kahook from the University of Colorado, and I'm really happy to be joining you today with some of the discussions that we've been having over the months, continuing into a new program that we've just started called Point-2-Point, which I'll describe here in a little bit. I do want to start off with a couple of slides here to do a proper introduction of the speakers, but before getting into that, I wanted to describe what Point-2-Point is. The last handful of calls that I've done through CyberSite, probably the last 6 or 7, oftentimes we run into the issue of running out of time. There are a lot of questions that come in, which is great. That's exactly what we want. But an hour just seemed not to be enough to get to a lot of the questions. So we're extending the period of questions for these point-to-point sessions. And we're going to bring in 2 discussants, typically 2 discussants who can field some of the questions. I'll be throwing out some of the questions and really going back and forth. We think of this as 3 friends sitting in a coffee shop talking about exciting topics in glaucoma. I also think this is a chance to take a little bit of a break from everything that's going on. The last time I was on was April 23rd, I believe, with Pradeep Ramalu and Hussam Ansari. We were right in the thick of things in the US with COVID. Everybody was uncertain about what was going on. You can see the telling look on Sarah's face. She's in New York and she was going through, through a lot during that time. And I was really hoping by now that we would be through this, but we're starting to see numbers going up. Friends in India and Australia are going through big elevations right now, including us in the United States and various states. So let's take this time and talk about medicine, talk about glaucoma, try and put some of the worries to the side for a little bit during these couple of hours. And I hope you can join us in doing that and just learning, taking this time to learn. I do want to take a minute here and introduce, as I said, the panelists. The first is Sarah Van Tassel. She's Assistant Professor of Ophthalmology at Cornell, Director of the Glaucoma Service and the Glaucoma Fellowship. She has a great pedigree here that way outpaces mine. She attended Cornell Medical College. She completed her residency at Cornell and then Duke Fellowship. She was a Heed Fellow. And she's a founding member of the American Academy of Ophthalmology's Resident Self-Assessment Committee. She's also a rising star in glaucoma. And I used to hate it when people said that, about people around like, come on, I'm a star already, right, Sarah? But definitely somebody who's a rising star. And I think you guys are all going to enjoy listening to what she has to say. As opposed to a rising star, a star who's been up there for a little while, Syril Dorairaj from the Mayo Clinic. Syril has had a lot of great training, and I try to condense it here with his permission. Residency at the New York Eye and Ear. He did a lot of his training in New York, also spent some time with Jeff Liebman, Celso Tillot, just some of the greats in glaucoma, and then went on to fellowship with Bob Weinreb at UCSD. He's a global key opinion leader on many things, including imaging, and in my opinion, one of the people that I go to for angle closure glaucoma. So we're going to have, like I said, most of the time is going to be for question and answer, but I wanted to set things up, and I'm going to be completely transparent with you. When it comes to angle closure glaucoma, it's not unusual for me to go grab a book, the basic series textbook, and read about it because definitions change, classifications change. I have a couple of things here on the slide just to get you thinking, and I'm going to keep this slide up for a lot of the time. Primary angle closure suspect, iridotrabecular contact for greater than 180 degrees, but no evidence of TM or optic nerve damage. Primary angle closure, iridotrabecular contact greater than 180 degrees with elevated IOP or PAS, but no optic nerve damage. And then going to primary angle closure glaucoma with, it's basically the same as PAC with glaucomatous optic neuropathy. The way that I tend to think of it, and we can get into this a little bit during the question and answer, is more from a mechanism standpoint. Is the iris being pushed forward, pupillary block, malignant glaucoma, ciliary body swelling, or is the iris pulled forward, contracting membrane, something like ICE syndrome? And the reason I do that is because it helps me understand what I need to do. Do I need to do an LPI? Is an LPI not going to work in this specific case? Do I need to take the patient and do lens extraction? And these are all things that we're going to talk about today. And you see some of the risk factors on the bottom left-hand side that I think are common to a lot of publications, just going through some of the risk factors. What we're going to do right now is start off with handing it over to Syril Dorairaj. He's going to go over a few of his slides for about 10, 15 minutes to kind of set the stage for the discussion. And then after that, we'll get to your questions. I'll encourage you during his talk to start sending in your questions. I have two computers, so I'm monitoring your questions as they're coming through on the left-hand side. And Syril, if you can take it away, and then we'll get started with question and answer. Thanks, Syril.
Thank you, Malik. It's a pleasure and an honor to be sitting here with you and Sarah to discuss something very key points about managing angle closure glaucoma from acute to zip. You know, before we actually go into understanding the management part, it's very important for us to understand that this glaucoma is not, though it's angle closure, it's not the same everywhere in the world. So because that's where I'm going to start with. If you know, this is a preventable disease. Angle closure glaucoma is one of the leading cause of preventable disease. And sometimes, time is very essential. Like if you can detect it in time, that there is a progression of visual loss or there is a progression of glaucoma, if you intervene and do something about this, you can actually prevent it from getting worse. But the most important point in actually the diagnosis is the most important point. What we have to do is, the very key point that we have to do is to do a dynamic gonioscopy in understanding the angle closure. It kind of it's very essential. When I was a resident or when I was a medical student in 1992, I used to carry a book called Bailey and Lowe. Probably people from India and Asia can actually know that when you are a surgical resident, you carry this Bailey and Lowe. And then this book, the first page in this Bailey and Lowe, it will say, if you don't put your finger in it, you put your foot in it. What does it mean? So when I was a medical student, if you are in the ER, if you have an acute abdomen patient, now we have CAT scan, we have all those things that we have to do. But there, during the emergency exam, it's very essential you have to do a parectal exam on all acute abdomen patients. Exactly the same way, if you want to diagnose angle closure glaucoma and you're going to go to the next steps in the management, it's very essential you have to do a gonioscopy. And it's very important that you have to do a dynamic gonioscopy. That kind of changes the complete understanding, because the dynamic gonioscopy actually gives us a clue about where exactly there is a blockade. And then so you can focus on relieving or taking care of that. So based on the gonioscopy, this is as you said, I've been doing a lot of imaging, I did 2 fellowship in imaging. So my key point is whether it's a posterior pushing mechanism or a pulling mechanism, broadly you can classify 2, 3, or 4 different types where exactly the blockade is. The pupillary block, also known as a relative pupillary block, happens in almost 70% of the patients, where the iris is more kind of convex. You don't have any mechanism why this convex mechanism happens, and there is some sort of a closure of trabecular meshwork. And then the next level of obstruction is actually from the ciliary body, where there's a large ciliary body which is kind of pushing the peripheral iris more anterior and closing the angle. But here, Malik, people would use words like rotation. I would never use a word called rotation in these circumstances. It's actually anteriorly placed. Rotation is where, as you said, malignant glaucoma, where the ciliary body is actually rotated. The next cause that I would say is the lens-related cause. During my first residence in 1990s, I would see actually a very mature cataract that can have actually causing this. But now, even now, if you can look at lens-related causes, especially in the United States where I'm practicing, it's becoming more common, especially in hypermetropes. So the key point, where we are going towards, to lay a few points about how we are going to manage from acute to zip, the key point is to understand where exactly the blockade is. So we have to do indentation gonioscopy. Otherwise, whatever the mechanism, whatever the classifications that you did, primary angle closure suspect, or primary angle closure, or primary angle closure glaucoma, anything that though it's broader, we don't understand where exactly the blockade is happening so that we can focus on taking care of that. And also, when you're doing gonioscopy or even imaging, there are a lot of things that kind of interferes in the actual diagnosis. For example, if you're going to do a understanding of where exactly how narrow the angles are, if you're saying 180-degree closure, based on primary angle closure suspect. If you're going to see a temporal quadrant of like 180, 90, it's going to be open. You're going to miss because in the fourth quadrant, superior angle is the most narrowest of all. Based on how broad the iris root is, superior angle is the most narrowest. And then the next is lighting. So if you're going to do a test, especially a gonioscopy in a broad, like in a very bright light, you're going to miss it. It has to be done under total darkness. And then the accommodation state. If you're going to ask like the patient to focus at certain point, and then if you see the iris itself kind of like goes more convex over time. So the accommodation induced by looking at a particular point can cause more convex iris configuration that itself can give you an idea saying like, oh, this is angle closure happening. And then the mechanism of like what exactly, what kind of lens that you're using, whether you're going to use a Goldman lens or a Zeiss lens. You can't use a Goldman lens, which is like around 11 millimeter to do an indentation gonioscopy. And then to understand if the patient has plateau iris or lens related, you need to have something very small, which can indent the center of the cornea so that you can actually see the mechanism. So if there is one point that if I have to tell about what's happening, the one point is do your gonioscopy in total darkness. There's almost 95% chances you will detect angle closure in this. And then the next point is the disparity. If you look at the paper that came over in 2014, Tham's paper, like they said, in Asia, it's much more common than Caucasians. The problem is we are missing it. We are not actually doing gonioscopy in this. In India, when I did my first residency, like all I had is like a flashlight. And then I had to just see whether Van Eyck and then see whether this patient have narrow angles or not until the patients come to ER with an acute angle closure. So if you are diagnosing in the ZAP study or the other studies, which is coming with a lot of imaging and other things, the main point is we are missing it because we don't do gonioscopy. Even if you look at the Medicare data from United States, not all physicians are doing it. So that is the main thing. So even if you look at the paper that got published, only there were 7 publications that they took into angle closure, and most of them are from Asia, and there is no particular way by which the gonioscopy was done, and they were missing it. They're basically missing it. So the data, what it's like actually is not actually a true reflection of what's happening in terms of angle closure. So the next thing is my fellows, I do see fellows from Nigeria and West Africa. You see towards the left side, that's what she showed. Like you actually see, you have a slit lamp, but you don't have a gonioscope. You have a slit lamp, but you don't have power. You're just using a flashlight to see and do a gonioscopy. So there's a lot of discrepancy in how we diagnose angle closure, and that itself will kind of gives us a clue about what is the mechanism of angle closure so that we can go to the next step. And this is one of the studies where I looked into whether there is actually a difference, whether there is an actually difference from Caucasians to Chinese or like from Asian eyes, why those people have more angle closure compared to us. So this study was published in a British Journal of Ophthalmology in 2010. Yes, we are different. Our eyes are different. People with Asian origin have far more risk of angle closure because they have a smaller anterior chamber depth and also anterior chamber width. So the mechanism, though we are kind of learning from a lot of papers, publications, prospective data coming from China and other places, it's not a true reflective. So we just can't take those points and say, this is exactly what we can actually do it for our patients. If somebody in Eagle study are saying, oh, let's do this, this is what the truth, and we can do it in China or in here. No, it's not. So you need to be more focused towards your local population. So this is another study that I did when I came to Mayo Clinic here to see, am I missing angle closure here in Caucasians? Yes, that's a possibility, because what's happening is when I did, because here at Mayo in Florida, it's predominantly Caucasian population. And then we actually looked into the mechanism, almost like 70% when compared to other Caucasian population studies, 70% have relative pupillary block mechanism, almost 25% have non-pupillary block mechanism. It can be lens related, or it can be just plateau iris and other things. So I know with the time, like I'm just going to run. So it's very important that like clinically significant angle closure is a neglected concept. It's a neglected point. And it can be variable. It can be variable in United States. It can be variable in China and Europe, in Africa. So it's it's very important that like we have to do a gonioscopy in dark to actually detect. And then if you can do a dynamic gonioscopy to actually understand the mechanism, it's very important to actually like focus your next step in management. In the Caucasian population, what I have noticed is people who are a little bit older, like 60 and above, they have more lens-related causes of angle closure. Younger patients have relative pupillary block mechanism angle closure. So whatever we talk about, whether doing a PI or a lens-related, Eagle study, a clear lens extraction or a cataract extraction, it's more focused towards your own population. That's what I learned in this study, which just got published. So this, I will leave you with this slide, Malik. This is one of these slides that like I actually made by my patient from New York. Like I told her, I'm going to do a cataract extraction. She was 50, her pressures were high. I did a PI, it didn't work. She was on 3 medications. And I told her, this is not going to improve your vision, but I have to do a surgery to protect you from losing vision. She got like, why are you doing this? She didn't understand. But after the lens extraction with goniosynechalesis, she was so happy. She's not on any medication. It's almost like a reversible disease. So the key point here is it's very important for us to understand the mechanism, what really is happening, and then focus towards the next point of management, whether it can be acute angle closure or Z. Thank you, Malik, and see you.
That's great. Yeah. Can you send me that cartoon? I'd like to have that on hand.
Sure, of course.
I'll take over the screen here. I'll reshare mine with that slide that we were talking about. And, some of the questions are already coming in that I think that talk highlighted a lot of the sort of bread and butter things we need to know about angle closure. But I think in a way, it also shows the complexity of how we think about the disease and trying to keep it straight. So for trainees, for residents, for fellows, people who are just starting practice, including seasoned ophthalmologists, we have to have some ways to make it work for us, not just in our patient population, but also in our head, how we see patients and how we decide to either intervene or not intervene. Do we do LPI? Do we do lens extraction? We'll talk about all of those things. One of the first questions that came in, Sarah, was about just diagnosing what you're seeing. So if you're looking at the angle in your clinic, so just regular clinic, not talking about an academic research project or anything like that, how do you actually document what you're looking at with gonioscopy? How do you go about doing that?
I think that's a great question and a tough one, because in part you're making notes to yourself so that you can take good care of the patient, but in part you're also making notes potentially for your colleagues or for a future person that's going to care for that patient. So I try to just be as clear as possible. And I think for me, that means simply describing the structures I'm seeing rather than using some kind of complicated system. So my notes typically say things like ATM 360 for anterior trabecular meshwork, or PTM and whichever quadrants I see posterior trabecular meshwork in, and SS for scleral spur, or CBB for ciliary body band. I like to just describe what I see. And I think that question also asked about von Herrick in reporting angles. I tend to rely less on that, but I do like to make a note to myself whether the anterior chamber is deep, moderate, or shallow. And there's some subjectivity to that, but I think you can use your own judgment to kind of describe that.
Yeah, Cyril, what do you do? I assume you don't do, UBM on everybody. I know your background in doing a lot of UBM, but what do you do in clinic?
No, not really. Whether they're open angle or narrow angle, whatever it is, gonioscopy is one of the very essential step in my practice. Whether, every year, even if they're open angle, they have to undergo gonioscopy. As Sarah was saying, the key step is to understand the structures, because almost 50% of the time, if you look at the data, a comprehensive ophthalmologist is actually looking at something, but it doesn't know what exactly it is. So if you are looking at a exfoliation and then there is a pigment, we actually don't know whether it is the pigmented trabecular meshwork or something else. So it's very essential to actually document the structures that you're seeing. So though you have put something about primary angle closure, suspect, primary angle closure, and then primary angle closure glaucoma. There are 3 different things. If you see trabecular meshwork greater than 180 degrees, does it mean it's primary angle closure suspect in a static gonioscopy? No, it's very essential that you have to have a style of how you do a gonioscopy. for me, as I said, every structure that you see, whether it's a trabecular meshwork, how well you see the root of the iris, how much pigmentation is there, color of the iris, and then every quadrant. And then when you do, you make other things stable. Whenever you're doing gonioscopy, it's very essential that your lights, if you're going to do it under darkroom condition, it's very essential that you have to document it, that you did the gonioscopy in dark. Otherwise, one of your colleagues will come and then he will do the same gonioscopy in full bright light, and then you will see structures entirely different. So that is the problem with gonioscopy. It becomes more subjective. So like I'm seeing something and my colleague is seeing something, and he will diagnose this patient doesn't need a PI, and I will be diagnosing no. So that is why it's very essential. It's not only just what the structures that you see, the quadrants that you see, it's also important the lighting and also like the lens that you use. If you're using a Zeiss lens and you're doing an indentation gonioscopy, you can actually see the plateau iris configuration or plateau iris. That's where you, but if you're using a lens which is like a Goldman lens and then you're trying to indent, you're not kind of like documenting it's not a dynamic gonioscopy. So it's the structure, the lighting, the quadrant, how the lens that you're using. It's an art. Unfortunately, as I said, like it's something that we have to teach our residents, our fellows. That's very key, essential point in our understanding of glaucoma itself, whether it's open angle, closed angle, gonioscopy. Like though there are different, grading systems. It's important for us to like actually teach our residents and then keep showing them, and also for them to have a particular style they will develop, so that when they go back, they will repeat exactly the same steps. The turn off the light, use the lens like this, use the not much of pressure, put your hand on the cheek, and then do the gonioscopy, and then do a dynamic gonioscopy, and then have some documentation. So, and you should also understand, Malik, what is that you are trying to, diagnose there? Are you trying to diagnose there is an oppositional closure? Or are you trying to diagnose there is a synovial closure? Or you want to do a PI or not? Or you want to take the patient for a lens extraction? So without an objective of like what you're going to accomplish, there is no point doing any testing. So if you're going to do gonioscopy, why am I doing gonioscopy? Am I trying to understand if the patient needs a PI? That's very essential. Like, we have to make our residents and fellows think like that. Why are you doing this test? Are you just doing it just because you have to bill? Or like, what is that you're trying to understand? Because like over time, even open angle glaucoma, my colleagues from India, like other places, can also know that open angle can go into closed angle. It can happen. It can definitely happen. So every
Syril,
patient.
Since you started answering the question, about 100 more people signed on. So I need you to repeat everything that you just said. No, so I think here's what my question is, and that could have been a book chapter, right? I mean, that was you're explaining exactly how you progress through things, which is great, right? That's the kind of stuff that at least I want to hear. But we had about 1,500 people register for this, right? So you have people from various practices all over the world who are listening to the answer, and I can tell you if I'm being honest with how I'm receiving the answer, if I'm in a busy practice seeing 30 patients in a half day, and I'm thinking about doing all of these things, it's not a surprise to me that a lot of physicians forget to do gonioscopy on specific patients. It's because we're overwhelmed in clinic. So, Sarah, how do you do things in your clinic? And do you have any sort of tips or tricks for people about incorporating gonioscopy into your practice, which is central? And as an aside, if anybody who's listening in, if you go to the CyberSight library and look up some of the stuff by Lee Allward that's in the library, I think that would be a great start for a lot of gonioscopy stuff. And his gonioscopy.org website is amazing for a lot of basic foundational skills. But how do you think of this, Sarah, in clinic? And do you do all of the things? And do you think through the whole process that Syril did? Or are you on patient number 15 and he's still doing gonioscopy on patient number? How does that go?
Yeah, to echo what you said, I think that the gonioscopy.org resources are just outstanding. There's a question in the queue about how do you become an expert in gonioscopy? And I think the answer is you do it a lot, and then you use excellent resources like gonioscopy.org. But I think in my clinic, I make it a point to gonio every single patient that I've never seen before. So every new patient to me, whether they're new to my practice completely or whether they've seen one of my colleagues, but they're seeing me for the first time, I gonio all those patients. And my technical staff knows that that's my policy. So they'll come knock on a door and interrupt me, quick gonio, and I'll, run out of the room, gonio that patient, and then pop back in. And the truth is, once you've become really skilled at gonioscopy, it's not scary, and it's not quite the time sink that it is when you're first learning. And then in terms of other patients, I try to do it yearly. I know there are patients who fall through the cracks, but I'll make a note about when I want to gonio them next. And I gonio every patient that comes back with a pressure that's higher than I expected based on their last visit. So any inexplicable pressure elevation buys someone a gonio, essentially, because you just have to make sure, do they have new neovascularization of the angle? You cannot know that without gonioing. Do they have they newly become occluded when they were open previously? Are there other clues about what might be going on? I think one of my mentors, Nate Radcliffe, says if the eye is numb, throw on a gonio lens. I think that's a good policy also. A lot of patients will already be anesthetized when you're seeing them because they've had Goldmann applanation tonometry, and it's pretty quick to take a look. So if they haven't had it in the year prior, it's reasonable to do again.
You just lost a lot of credibility by telling us who your mentor is. There's no going back from that. One of the things that can be a little bit embarrassing when you're training residents and fellows, our fellow last year was actually Sarah's resident, Monica Ertel. She came to us for fellowship, and she would go into a room, see a patient, come back out and say, it's been 2 years since we've done gonioscopy on this patient. It hasn't been documented. I'm like, yeah, it's exactly what I intended. This is a unique situation. But then it happened a few times in the same clinic. So even though I'm focused on doing gonioscopy, no matter what, you're going to miss some of the yearly visits where you're trying to do gonioscopy. And I would encourage everybody, just do the best that you can. Hopefully after this discussion today that you're thinking about gonioscopy, you're incorporating it in. It's kind of like when we tell patients how to remember to use their drops. Sometimes we say, just put it by your toothbrush and you'll remember to do it. And the patient will say, well, I don't brush my teeth every day. In our case, we have to kind of do it with something else that we're routinely doing in clinic so that we don't forget. I wanted to ask a question of both of you, and I'll start with you, Syril. This is a question that's coming in from Gabo Lazcano, one of our friends who is in Puebla, Mexico. He says, do you perform provocative tests on angle closure suspects? Do you do that, Syril? Provocative testing?
So the provocative testing is like, if you're going to do UBM or anything, how are you, like my way of actually documenting for angle closure provocative testing is doing a UBM in light and dark. So that's kind of like a classic way. That's how I learned. And then if I notice the same UBM, if you're going to do in each quadrant, superior, inferior, temporal, and nasal quadrant, and then when you totally shut down the light and then do the same testing again, there is almost like, as I said, like I published on this topic, there's 90% increase of detection of angle closure. So this is the provocative testing that I very typically do in my office even now. So, and I also use imaging to objectively quantify it. So though like I'm doing the gonioscopy in dark, but like when I'm actually doing a provocative testing, I want to actually show the patient the risk of having an angle closure, or what is happening, the angles, whether it's open or closed, or what is that like, it becomes much more easier for me to explain to them if I have a picture and doing a provocative testing by doing the UBM in light and dark. And I also do like the anti-segment OCT in light and dark just to like show them, this is the provocative testing I very typically do. The other things like, prone position testing, or even doing like, darkroom test for almost like 15 minutes. Mm-hmm. All those things is not kind of like feasible in my office. At this time, I just do light and dark UBMs.
Okay. Sarah, do you do anything specific that's, different than what Syril is saying, or are you pretty much in line with what he's saying?
I don't really do any provocative testing. I'm not confident that it has been well justified in the literature. And honestly, I don't have time for it in my clinic. And so it has not been something that I've routinely done. I will say I do occasionally, for various reasons, dilate someone who has appositional contact of their angle but does not have glaucoma. And for whatever reason, the rare occasion that happens, I do routinely check the IOP after dilation. So that is, in a sense, a provocative test, but I'm typically not dilating them for the purpose of provocation. I'm dilating them for another reason.
Okay. Can you tell me a little bit about indentation gonioscopy? So when you're doing it in clinic, is there a particular lens that you use? There's a question in here about using a pediatric gonioscopy lens. And
yeah, I saw that question. I don't even know about pediatric gonioscopy lenses. It's something.
That's because Nate Radcliffe is your mentor.
I mean, that's right. I use a Volk Formier, and I do indent. I think the important thing about gonioscopy is making sure that you've taken your full look and that you're happy with the gonioscopy you've performed before you indent, because you are, in a sense, sort of ruining the virgin gonioscopy once you've started to push on the eye. So you want to make sure that you're almost, I tell the residents, like you're ice skating over the ocular surface. If you're not occasionally seeing air in the interface between your gonioprism and the tear film, then you're pushing too hard. It should really be very gentle contact, because you want to see what the angle looks like with no pressure at all. And then once you see that, I think it's reasonable to then apply pressure, because that can orient you more to the angle structure, in particular in someone where you see a little bit of pigment and you're not sure, is that a Sampolisi's line, or in a person with an otherwise appositional angle, or is that PTM? And then you press on the eye. That, in many people, will then open the angle structure such that you say, that's scleral spur that I'm seeing now, and PTM that I'm seeing now that I wasn't seeing before. So in fact, this is an occludable angle, and what I had been seeing was, some pigment on the termination of desmase. And so I do routinely perform indentation gonioscopy, but I think it's critical that you do your gonioscopy before you indent.
Okay. And Syril, let me touch on a question for you that you brought up briefly, maybe in a couple of minutes. Just describe, when do you use UBM? When do you use anterior segment OCT? What are the benefits and drawbacks of using one versus the other?
Okay. So do you want me to talk about the indentation gonioscopy also?
If you want to, but you get 30 seconds for that one.
Okay, let's leave it then. So because I can't stop it. So the UBM and anterior segment OCT. So Malik, as I was telling you, like any test that I perform, there is, I want to know what is that I'm getting out of it. Yeah. So the difference between UBM and anterior segment OCT is anterior segment OCT is a 1310 nanometer light, the laser light, which kind of can be stopped by the pigment epithelium from the iris. So it's not going beyond the iris. So anything which you are just going to rule out whether the angle itself, how open it is, what are the angle structures that you are seeing, whether it's an oppositional closure, or even if you look at the configuration of the iris, if it's a synechial closure, then you can make a diagnosis based on the anterior segment OCT. But if you want to see the structures behind the iris, say ciliary body, if you're having something like a posterior pushing mechanism, as you have pulled it there, anything that's kind of pushing it from the back, that's kind of pushing the peripheral iris to close, then that's where the UBM comes. When I used to do UBM in 2005, it's much more cumbersome test. It's as if you are doing a water bath. All this is much more riskier. But no, the fourth generation UBM is far more easier, and it's almost like an anterior segment OCT, and then you can get a lot more information, especially about the ciliary body or anything, especially where the posterior pushing mechanism is happening there. So but when you look at the clarity of the structure, it's almost like 1 micron. It's almost like 1 micron. So you can actually make more diagnosis with UBM than with the anterior segment OCT. When you do gonioscopy, anterior segment OCT is same equivalent. But if I want to show it to my patients that what I am seeing with an gonioscopy with the anterior segment OCT, I take and then show it to them. So it's kind of more objective testing, anterior segment OCT. It's more done for patients and then showing it to them what's really happening to quantify the angles. But if I want to actually understand the mechanism of angle closure, I do more UBM.
So I remember when I was in fellowship, the Visante OCT was sort of in vogue then. We were doing a lot of anterior segment OCT with that device, and there was a lot of hope that it would replace gonioscopy, or at least the variability in gonioscopy, and that didn't really pan out. We have better devices that have more, that are better at imaging, I should say, from a size standpoint, right? We can get down to smaller features right now, but it's not routinely used in clinic. What do you think about that, Syril?
I agree, Malik. Visante, it went out of market. The problems is it's a 1310 nanometer light. It's something very similar to what the higher definition spectral domain OCTs are. But the problem is dewarping the image. For example, if the light is going at the center, it goes like straight. But if it's going at an angle at the periphery, the way it recreates the image, it can give a lot of false images. So that is where we had some problems with the Visante, how the images are dewarped, and the actual image is actually what you're seeing might be entirely different.
Right.
So the reflections of light is very different. But now the current generation, there are a lot of newer versions coming with like a spectral domain that you can actually see almost the Schem's canal in almost every patient easily.
Right. Yeah.
And then, you can actually see much more deeper structures also much more faster. Within 20 seconds, you can zoom 360 degree, and then it has artificial intelligence, which pinpoints to the scleral spur, which actually picks up the scleral spur and then shows whether there is an oppositional closure or a cynical closure, which quadrant is closed. Everything is fast, automated, objective, but unfortunately not everywhere in the world people can afford this.
I mean, that's one of the problems, just situational issues like that. There's one thing I wanted to point out before I get to a question. Mina Pancheva, who's my partner here at the University of Colorado, just a statement. It says one can also minimize the length of the slit beam, not to shine in the pupil and provoke meiosis.
Absolutely.
So it's just something that wasn't mentioned out loud, but I think we all
absolutely. I totally agree.
There's a question here that's it has to do with sort of the introduction where I was talking about COVID and how things have changed, and try and forget about that. I guess I'm going against my own statement of trying to forget about things for a couple of hours, because there is a question that I think is really good here. And it says, in these challenging times of COVID, do you routinely perform gonioscopy? And this question is good for you, Sarah, since you were, you're in what was the epicenter in New York. You saw a ton of patients. I know, you and I've talked about some of the stuff that you guys went through. Do you change your practice? And maybe it's not just gonioscopy. Maybe we can touch on visual field and OCT testing. What are you doing that's differently? And then Syril, I'll have a different question for you to follow.
Okay.
So when New York City was at the peak of the epidemic, sort of late March and early April, I was not seeing as many patients as usual. And I made a concerted effort to judiciously perform gonioscopy in patients in whom I thought it would make a difference in their clinical management. Incidentally, that was actually a high proportion of patients during COVID, because many of the people I was seeing were neovascular glaucoma and acute IOP elevations, people whose eyes were pretty sick. Now that we in New York are doing pretty well, knock wood, I am back to routine gonioscopy. We do have the availability here of the disposable Katina gonioprisms, and I think it's unfortunately not a viable option for sort of a sustainable protocol, because the lenses aren't cheap. They're about $9 or $10 each, and so to throw that down the drain just doesn't make sense long term. But we have used those in certain instances. I'm cleaning my gonio lens with 70% isopropyl alcohol and letting that dry. And I think that's consistent with the best policies from the American Academy of Ophthalmology and from the CDC in terms of limiting disease transmission. But I think it's hard to compromise on gonioscopy, because it is so critical, I think, for making the proper diagnosis for patients and for taking good care of them. I think to echo what we were speaking about earlier in terms of the dark room gonioscopy, that is actually what has become increasingly challenging in my practice, because we are now routinely leaving exam room doors open,
right,
to allow for optimal air ventilation in our practice, which is a dramatic change from prior. But that means there's sort of an extra step now associated with performing gonioscopy, which is to say I have to close the door in order to create complete darkness for a few moments.
Yeah, and Sarah, maybe you can answer the visual field OCT question just briefly. What do you guys do differently between patients? Is there a cleaning protocol that you do, or do you alternate devices? What do you do for other testing?
It's still like it's exactly the same situation here, but like we are taking all the precautions here at Mayo. Like after every patient's, there is every room is thoroughly clean, including the slit lamp. And then currently, like I'm using the disposable gonioscopes. If it has to be reused, of course, we use the isopropyl alcohol, clean it up, dry it, and then we are using it. For the visual fields, again, we have 2 rooms, and then we are kind of like having this social distancing and all those things, those criteria. And then we are also wiping the visual fields, the dome, and then making sure the patient wears the mask. And probably like you would have known, AGS kind of like sent out some guidelines about how to clean the visual fields. And also like, there will also a factor, like when the patients wear the mask and do the visual fields, there is a risk that they might have some new visual field defects also. We are kind of like told the technicians about what to expect. These are all new things. If they find something unusual when the patients are doing, if they're taking a little bit longer and then more past test is a little off, like then like we are kind of like going very slowly, not only just cleaning the the visual fields, it's also like making sure it's repeatable.
Okay. Now that's, we're all going through this and learning together, right? We get great recommendations from Academy, from AGS, from different, groups around the world who are talking about their experiences. That's how we found out about some of the visual field defects that are mask related when people are wearing those. Certainly we're seeing those are fogging up of the lens and issues like that. One thing I wanted to touch on here before moving to some of the other questions, and I'll just reiterate to everybody listening in, please send in your questions. We're getting a ton of questions, and I'll try and get through as many as possible, including some of the questions that were submitted even before the session. You guys can see this picture here in front of you. This is a patient who is post-LPI. Sarah, what did I do wrong here?
This LPI is right at the lid margin. You're highlighting it with your arrow. So this means that unfortunately, each time this patient blinks, because of the prismatic effect of the tear film, potentially they are getting a little beam of light stimulating their retina. And there are few things more annoying to patients and probably nothing more annoying to doctors than that beam of light.
Yeah, I wanted to touch on this. I'm going to show a couple of slides here, and then I want to talk to both of you about some of the issues before we move on to a slightly different topic. I showed you guys this slide before we hopped on the Zoom meeting here. There was a lot of debate a few years ago about whether we should go superiorly or if we should go temporally with our LPI. Initially, I was doing everything superiorly at 11 or 1 o'clock. And I was doing that because that was the way that I was trained. I avoided 12 o'clock because bubbles can actually, hinder your view after you do a few shots. When I started going to temporal, there was a lot of benefit. In this case, you can see we're away from the eyelid. The other benefit that isn't talked about as much is the ciliary processes are a little bit longer and encroach on the peripheral iris a little bit more when you're temporal, so they can block some of the light going through, which I think is one of the advantages. And certainly in my experience with the temporal LPIs, we've seen less of an issue when it comes to patients complaining. And there have been some studies looking at this, and like everything in glaucoma, the studies kind of disagree with each other as to which way to do it. This is from Spaeth and colleagues, where they found greater than 90% of the LPI patients had no issues. Around 9% of eyes with completely covered LPIs had an issue, as opposed to 26% with partially covered LPIs having visual disturbances, and then 17.5% with fully exposed LPIs having issues. This was not a prospective study. The questionnaires were prospective, but the patients were done years before the questionnaires were actually implemented, so a slightly different design. And what they're saying here is visual symptoms following LPI are more likely to occur when you have a partially or fully exposed laser iridotomy as opposed to having something that is fully covered. Now, this came out from Pradeep Ramalu and a few others, as you can see listed here. This was a prospective study, randomized, but the randomization here was by patient, not by eye. So there was no right-left eye comparison of temporal versus superior. And they got a questionnaire 2 weeks after the LPI. So there's a question here of whether that was enough time to show some of these issues that can arise. Or does that change after 2 more weeks at a month, which some other studies looked at a month timeline instead of 2 weeks. And they recommended that the LPI should go where it's easiest to access, so that there wasn't really much of a difference with visual disturbances superior versus inferior. I actually emailed Pradeep yesterday just to get his thoughts on how he would do things differently. And he said, no, the study was perfect. I wouldn't change anything. He didn't say that. No, he said that what he would do is he would take pictures of all the peripheral iridotomies, so that there would be not just the physician saying, I did it here, but there's actual documentation of it, and also doing a pain scale. So was there a difference in discomfort, temporal versus superior? One of the reasons for that is this study. This is by Ver and colleagues. This is Ike Ahmed and friends. Where, again, prospectively, but in this case, they randomized within the patient. So each eye got a different type, either temporal or superior, and the patient didn't know which one was which. And they came up with slightly different conclusions. They also looked at pain. And what they concluded here is that temporal placement of LPI is safe and was found to be less likely to result in linear dysphotopsias, but there was more pain, right, with the temporal. So that's a really important point, that it isn't as easy as saying, I'm always going to go temporal. Right? There are some cases where you're going to go superior, especially if you can get it completely under the lid. Because we don't have, a ton of time to go through all of this stuff, I just want to see if you guys can agree that from a setting standpoint, this is what you guys do. I mean, from an argon laser, kind of an outdated term, argon, right? So diode laser. With lighter irides, we use a longer pulse. With brown irides, we usually use more spots, 25 to 100. And I'm showing these here, so during the recording, people can go back and kind of look at the numbers. They don't necessarily have to, write down all of the numbers at this point. And then, of course, we have 2 different methods. We can go with a thermal type approach, or we can go with a photodisruptive type approach like Nd:YAG laser. And in this case, 1 or 2 pulses usually can get you through, and you don't have to really, you can pretty much do any type of iris, right? The very thick iris or the very thin iris when it comes to Nd:YAG. And usually if we're using pilocarpine, we can get through with 1 or 2 spots. This is a link. Hopefully you guys can see this link. My screen is very full of different boxes. I don't think that's your view. I think you can see the entire slide here, I hope, at least. This is, I recorded a small talk on LPI, settings, side effects, adverse events, why we use a lens, different lenses. So you guys, whoever is interested can go to this YouTube link and watch the whole video. It's about 10 minutes long or so. When it comes to temporal or superior placement, Sarah, what do you do and why do you do it one way or another?
I'm junior enough in my training that Ike's paper had already made a splash in 2014 before I was really doing many LPIs. And so I think that the trend kind of shifted toward doing them at 3 and 9 at that point. And so I have pretty much done them mostly at 3 and 9. And honestly, I think it's a little technically easier also. They're easy to transilluminate in the office. You don't have to yank on the lid and ask people to look in all kinds of different directions. So I would say I'm not overwhelmingly convinced that the dysphotopsias probably differ all that much, but I'm happy to do them at 3 and 9.
Sarah, what do you do?
It's almost the same, Malik. It's in terms of, Pradeep's paper, what it actually said is true. Like, the dysphotopsia, whether you do it in superior quadrant or temporal quadrant, it's almost the same. But in terms of the pain, I do both. I've done both. I also have done surgical iridectomy, and I've seen, sometimes dysphotopsia actually depends on a number of things. It's actually the size of the openings that you create. If it's too big, or if it's having, kind of like hazy with a lot of fibers around, that kind of distorts the image, or if it's exactly in the lid margin, that's also a problem. And if you're doing it with a really thick brown iris and trying to get into in the superior quadrant where the iris is far more thicker, can be a much more problem. And then the inflammation is far more higher in them. And then when you compare it with the temporal quadrant, which is much more easier, and then, like in the lighter iris or blue iris or gray iris is far more easier. And you can actually easily transilluminate and then find out whether it's open or not. but there is no actual studies which actually like proved which is beneficial in terms of progression of like whether because like whether it's a superior quadrant, inferior or nasal or temporal. Superior quadrant is the most narrowest of all. And if you see if there is more opposition there, you are trying to open there, or like would it be beneficial to do that? Are you just placing a temporal quadrant will just completely arrest the progression? I have no idea about that. There is no actually a prospective study looking into it. But in terms of comparing the outcomes, especially the pain and the other thing, it's almost the same. I right now I don't have any kind of inclination towards one to the other.
Sarah, are there any cases where you do an LPI without a lens, without using an LPI lens?
I can't think that that's happened to me recently. I'll do YAG capsulotomies without a lens now and again, but I typically use a lens if I can. I like the stability of the eye, the control.
I think that's one of the major things. You have stability, keep the eyelids out of the way. It's safer. It's a little bit of a heat sink with the lens. And then if you do have a little bit of an ooze or a bleed, it's easier to tamponade that by pushing with the lens on the eye to control by increasing the pressure. Let's kind of switch gears here a little bit and start talking about lens extraction, more of the EAGLE trial stuff that's out there. And, Sarah, maybe without putting you on the spot too much, maybe just tell me your impressions of what the EAGLE trial says and then how you use that in practice. And then Syril and I can tell you why you're wrong after that.
You're getting me to talk.
This has been an exciting decade, I think, for laser trials because we now have, although laser techniques themselves haven't changed, we have a growing volume of prospective studies looking at things we maybe want to know about lasers. The EAGLE study was a multi-center prospective randomized clinical trial that looked at clear lens extraction versus LPI in patients who either had primary angle closure and elevated IOP, or patients with primary angle closure glaucoma. And there was more primary angle closure glaucoma in their group than primary angle closure. And essentially what they found is that at 3 years, on average, the eye pressure was about 1 millimeter lower in the clear lens extraction group than in the LPI group. That number, 1 millimeter of mercury, probably isn't clinically significant, and it's also not surprising because the practitioners in the study were allowed to treat to a target IOP, so not surprising that the groups would have similar pressures. But I think the biggest findings were that only about 20% of patients in the clear lens extraction group needed additional eye drops to meet their target pressure, whereas nearly 70% of patients in the LPI group needed additional therapy. And furthermore, with respect to moving on to glaucoma surgery, only one person in the clear lens extraction group needed incisional glaucoma surgery. 4 eyes in the LPI group needed incisional glaucoma surgery. And so they were interested in looking at safety, efficacy, cost, quality of life. They looked at a number of metrics. I think in terms of quality of life, it's not surprising that they found the clear lens extraction group did a little bit better, but I think you have to kind of take that with a grain of salt because clear lens extraction in a hyperopic patient is essentially refractive surgery. You're taking someone who, in this study, their range of refractions was between plano and about +3. You're taking those people and you're essentially making them an emmetrope. So people like improved vision. I think the cost data showed that there are more upfront costs with clear lens extraction than with LPI, but that maybe when you take into effect the quality of life, that starts to look acceptable over a longer horizon. But I think the most important finding is the clinical findings, the data that the patients tended to do better in the clear lens extraction group. I think that challenge here is thinking about the external validity of these findings. Typically, when I think about external validity, I'm thinking about whether or not the patient group matches my own practice. I think in this particular study, we also have to ask, does the doctor group match our skill set? I think when you're talking about clear lens extraction in a short eye, you're taking on some risk, right? A clear lens means that person was seeing okay before you touched them. So you want to make sure, you want to make very certain that they're going to see equally well, if not better, once you're done. And I think the other thing to keep in mind is that cataract surgery, clear lens extraction in short eyes is not always technically easy. I think the cataract surgeries that I do in short eyes and angle closure eyes are some of the toughest eyes that I do. And so I think that these findings are only applicable to someone's practice if they are a skilled phacosurgeon. And the group of doctors in this study were very skilled phacosurgeons, all well-trained both in comprehensive ophthalmology and in glaucoma. So I think that if you are in fact a skilled phacosurgeon, you can consider applying these findings to your practice. In my practice, I tend not to remove truly clear lenses, but I think that these findings motivate me to think about early cataract surgery in patients with similar findings, elevated IOP and angle closure or angle closure glaucoma. You know, if you might have been on the fence between an early phaco versus LPI.
And Syril, has the Eagle data that came out, has that changed your practice in any way? Are you more likely to do something after going through reading that study?
I agree, Malik. It's like if you see my ending slide was something very related to what the Eagle study was. The patient was like in his 50s, a female with you know, more than pressures of 30 with Syneque. But like one thing is like if you look at the data much more closely in the Eagle study, what you have to see is who are the patients who underwent you call clear lens extraction. If you see the age of those patients are around in your mid 60s to, you know, around 65, 67. So I did maybe like 18 to 20 cataract surgeries this week. You know, if in United States, let's not take my practice. If you look at the United States, average age of patients who are undergoing cataract surgery, according to the Medicare data, is 65. 65. Okay, so you have like, you know, and then the data here, like the Eagle study data, the patients are women, okay, predominantly like 60% of them are women. And also age is like around 67. And then the next point is almost 60% of them had primary angle closure glaucoma, PACG patients. So you have to look at the data, like, you know, you're not going to like, though they enroll patients 50 and above, you are not going to extrapolate it and then say, I'm going to do clear lens extraction on a 50-year-old. No, not really. Okay, right. So you have to, like, as Sarah was saying, doing a cataract surgery in an hypermetrop or like a smaller eye, there's more risk. You know, it takes a long time. You will end up with more complications. But so you have to look at the patient data and then extrapolate it to your patient population and then see whether this is what they're trying to tell you. They're like, you know, whether, but it's an option. In my practice, it's an option. You know, if a younger patient, primary angle closure glaucoma, pressures of more than 30, and then having a Syneque, these are the patients. But like if you look at the clear lens extraction who had benefit, almost 9% or 10% of them also had goniosynochilasis in them. Surgical, if you look at, they also had goniosynochilasis. It's not just the clear lens extraction they underwent. They underwent something else beyond that. So you need to see, you know, like these patients had something beyond just the cataract, and then they had some benefit out of it. And then if you want to ask me like whether I'm going to do the same thing, you know, like it's already the same thing that I'm doing. Like if you look at the data, like, you know, patients are in their 60s having some sort of like cataract. If they have angle closure, if they have Syneque, and if they are more than 30, it's given. It's given, like, you know, but this is a much more valid way to show it, and they proved it, and you should give it. But the point is, we should not take it to a 50-year-old.
So one point I like to make here is just for the point-to-point format, we're an hour in. This is usually when most of these programs would end. But now we have a significant amount of time to do questions and answers. So please keep sending in your questions. I'm looking at all of them, and I'll try to get to as many as we can. We're going to go for another, you know, half hour to an hour, as much as we need to get through a ton of these questions that are coming through. So Syril, let's just pivot a little bit to the ZAP study, the ZAP trial from David Friedman and colleagues. Can you just give, just a 1-minute blurb on what the ZAP looked at and sort of what the conclusion was?
They kind of like reflected a particular group of population. ZAP study is also known as Zhongson Angle Closure Prevention Study. The basic idea, the concept is to see whether doing a PI, LPI, in a patient who is diagnosed with primary angle closure suspect is someone with a static gonioscopy. If you don't see more than 180 degree of trabecular meshwork, would doing a PI in them benefit or not? So it's one of the largest, group of patients that were prospectively enrolled in Guangzhou province. It's almost like more than 800 patients were enrolled, and they prospectively did a lot of testing, and then they underwent PI in one eye, and then prospectively looked into whether these patients the other eye is going to develop angle closure, or if they're going to the next stage of glaucoma, or BACG, will they develop anything like that? So we might argue about number of things that, whether proposing a cataract surgery for someone or doing a PICP or iridoplasty on someone. But this kind of like gave an idea saying in one of the most riskiest population, we always think Asians have a much higher risk of angle closure. They kind of like gave an idea it's not really necessary because these patients don't really progress to develop an angle closure, and it was not of any benefit. This is an eye opener. This is like an eye opener.
So the laser.
I differ with the assertion that it didn't show a benefit, though.
Yeah,
I would argue. Their primary endpoints were.
It took an hour for the two of you to get in a fight. This is good. So go at them, Sarah.
So backing up, so that the listeners are with us. Eagle study is a different population, right? Eagle study is people with their angle is closed or partially closed, and they either have elevated IOP or glaucoma. Now we're pivoting to ZAP. These are just people who are seen in the community and screened for an occludable angle. So this is very similar in my practice to people who saw an optometrist in the community, for example, and were told incidentally that they had the finding that their angle is not open. And their primary endpoints were three things: elevated IOP greater than 24 at 2 visits, development of peripheral anterior synechiae, because none of the people had it at the screen visit, or an attack of angle closure glaucoma. And if you look at all three of those primary endpoints, almost twice as many people in the control group met that endpoint compared with people in the LPI group. And patients served as their own control because they had an LPI in one eye and no LPI in the other eye. So if we're looking at their primary outcomes, 19 treated eyes and 36 non-treated eyes met their primary endpoint. I think the more exciting finding is the question about acute angle closure glaucoma, because that's what these patients fear. They've been told when they're outside a general's office or an optometrist's office that they need to present for an LPI within the next 24 hours because they're going to go blind if they don't have an LPI. And what this trial showed us is that the vast majority of patients don't go into acute angle closure. 3 control eyes and 1 LPI eye went into angle closure with provocation, with dilation. And then 2 additional control eyes, for a total of 5, had angle closure without an attack of angle closure without provocation. So there is a benefit to LPI. It's just a far, far lesser benefit, perhaps, than we thought previously. The number needed to treat is very, very high. So I don't think we can say LPI has no benefit, but I think we can counsel our patients that one reasonable option in a certain context is perhaps observation.
Right. Let me ask you both. It's kind of a yes or no answer. For Syril, if you were in this category of narrow angles, let's say they're occludable, kind of mimicking who got enrolled into ZAP with all the criteria that Sarah just went over and that you went over, would you get an LPI?
So the argument is like whether, I never said I wouldn't do it.
Yeah. Would you do it on yourself though? Would you have me do your LPI? Yeah, I just confounded. I confounded the answer.
I would definitely do it. But the problem is, if you look at the data, they kind of like took away, as Sarah was saying, like whether I would do it, if it's just their findings. Mm-hmm. It's interesting to see the most riskiest population, who have like almost like 30 million people with primary angle closure suspect, having to say like, this is an easy step. I'm not going to argue with that. That's their finding. But who are the patients they excluded? They excluded patients on their whatever the prone provocative testing or darkroom testing. If they notice there is a IOP spike, they excluded them. So it's kind of like giving it to you, right? Mm-hmm. Like you're not taking patients who have the risk of acute angle closure. But if you look at other group of patients who had, probably you remember Walensky's study that came from Europe, mm-hmm. like 6% of his study population had an acute angle closure glaucoma, an attack actually. And then like when I was a resident, or like, it's probably like, you know Ravi Thomas, like he published a paper looking almost like 3 to 5 years, patients who are primary angle closure suspects, and then whether they will go in, almost 22%, 25% of the patient population within 3 years developed synechiae, glaucoma. And so it is a significant number in my patient population.
Right.
So I think I wouldn't take it. I won't take it. But like, you have to look at the risk factors, whether they're hypermetrop, how thick the iris is, how convex the iris is, what is their IOP, family history, everything. And then make I won't rush into like, oh, that is something that I've learned. Though there is some sort of like an oppositional closure, but if there is a cynical closure that's developing, I would definitely offer it to them, whether it's 5 degree, 10 degree, or anything like that.
I think what we're noticing in all of these studies, not just the LPI, symptomatic, mm-hmm. sort of visual disturbances, ZAP, EAGLE, is that a lot of times what we'll hear, what gets the airplay, is the conclusion.
Yeah.
And we talk to our residents and fellows about the conclusion. And early in my career, when I was in clinic and the resident would ask a question, I'd say, well, here's the conclusion. And now when I get asked the question, it's usually like, well, God, it really depends, right? And the past 15 years of practice has taught me that you have to do X, Y, and Z and pick this patient versus that patient. And maybe I don't pull the trigger to do a TRAB as fast on this group of patients versus that, because my experience shows that they're stable for years after a progression episode. So I think that's one of the take-home messages, is that on a format like this, when we're doing a webinar, we can kind of hit the highlights. And I think we did that for both EAGLE and for ZAP, but the encouragement would be to go and dig in and see how it applies to your patient population. And when the authors of ZAP were asked at a conference, I saw this on the internet recently, when they were asked if they would get the LPI, they're like, yeah, I'd get the LPI. So I think it really, we have to look at those, certain things. Do either of you do water provocative testing?
No.
Syril, do you do it?
Oh, like you're getting into a point here, like, because I have fellows and I have collaborators from Brazil.
Right.
Probably, Remo is a big proponent of water drinking.
He's the one who taught me about water drinking. So what do you do?
Actually, have you done water drinking test yourself?
I have not.
Kaveh made me do it.
Okay, I'll have to do it. If Kaveh did it and you did it, now I have to do it. Sarah, that's what we're doing.
No, whatever the concept is, like, the concept of, the choroid coming into picture, where there is extra load of fluid into the choroid, and then that kind of increases the chance of precipitating an acute angle closure, or increases chance of detecting. I don't buy it.
Okay.
But I actually published 2-3 papers on the validity, looking into some collaborators from Brazil. It doesn't have a place in my practice.
Okay.
I would say that.
I'm going to go through a few questions, and
Malik, do you do it?
I don't do it in clinic. I haven't done it myself, and maybe I should. Maybe I'll call you tonight after I've done the water. I'll have my wife call you, and she'll let you know how it went. So let me ask some rapid questions here, and we have a bunch of questions that we'll try and get through, and I'm going to go to random questions. They're not necessarily going to tie into each other, but let's just try and get through as many of these as we can. And some of these I'm just reading for the first time here. So the first question, this is for you, Sarah. If the elevated IOP and angle closure is caused by weak zonules in a short axis patient, so short axial length, LPI has been done in the past. Is this angle closure primary or secondary? I guess that's more of a sort of definitional thing, right? And
that's like philosophical or teleological. I mean, I think probably secondary in terms of how I would code it, but in this state's coding is more of a billing matter than a true diagnostic matter.
And that gets back to my initial slide that I had on for a little bit, that the mechanism is really what I look at. In that case, I'm thinking, how do I reverse this? So this lens has zonulopathy. What am I going to do to overcome that? It's really about the intervention rather than the classification.
I agree, Malik, because these are very typical patients with pseudoexfoliation.
Yes.
Pseudoexfoliation where, there is weak zonules, there is some sort of like lens-related lens-related causes of angle closure rather than the convex iris configuration. So zonular involvement, I would rather focus on the outcome is the lens moving forward.
Yeah.
Okay.
Here's pseudo-X, and then you also have to be careful, like marfanoid eyes can do that, microspherophakia. I would say in most of those eyes, the lens probably has to go, but proceed with extraordinary caution.
Yeah, lens has to go is the answer for most things in my clinic. So So here's a question, and let's go with Syril first. How do you reduce the risk of post-ND YAG or just general LPI complications like floaters? Is there anything that you can do, or, they touch on in this same question on shadows, webs, crescents. We talked about the positioning, but do you have a lot of patients who experience floaters post-LPI?
Unfortunately, no.
Okay.
Fortunately for me, no. So I typically I used to do maybe like 300 to 400 of this a year before, because I was doing a prospective study comparing enrolling Caucasian population here at Mayo. And most of them, if they decided to undergo PI, this population is entirely different. So, but even though it's uneventful, there is no bleeding, I still put them on, prednisolone, Predforte for like 4 times a day for 7 days and then stop it. In terms of floaters, I've not noticed that. I've not noticed it, though there is some data. My typical approach is to continue the steroids for 1 week and then stop it.
Okay. Sarah, do you use, thermal versus photodisruptive for LPI? Do you always use YAG? What are the circumstances where you might use one over the other?
I almost always pre-treat. Even in light irides, I find that you can sometimes find a slightly more pigmented area that perhaps you get slightly less bleeding and things are a little thinner. And I would say as a secondary benefit, I like to mark the spot for my trainees because I often do, especially with junior residents, I'll do the pre-treatment myself and then they'll pop through with the YAG. And I think it's nice to show them the spot.
Okay, that's great. I don't do that. So that's a really good point, and maybe we should be doing more of that. Syril, do you use either or how do you proceed?
I used to do argons exactly like the same way what Sarah was saying, especially when I was in New York. I used to pre-treat with the argon and then go with the YAG. But like after I came here, my patients here are lighter iris, blue, gray. It's easier for me to finish it within 2 or 3 spots with YAG. And then I just find a spot where I feel it's easier to get through. And I've stopped using it since last 8-9 years. So I just go with the YAG. What's your go-to lens, Syril, when you're doing LPI? Do you have Abraham lens? Okay. So the same Abraham lens. That's what I've been using. I've not changed anything. Okay, let's see this next question here. Does adding LPI, does adding argon LPI to just standard LPI lead to wider angle and more persistent opening? Maybe, I think they're referring to iridoplasty in this case, which we can get to in a little bit. Let's get back to that question because we're going to get into that topic here towards the end because I sense that's another fight between the two of you and I want to save that to the end.
So a question about posting reading info on principles of gonioscopy. Again, I think you heard from all three of us that gonioscopy.org from Lee Allward is the place to go. So again, the word gonioscopy.org, and he walks through everything. It's amazing. And he also has further content on CyberSight. So please visit the library on CyberSight as well. Hopefully that's helpful to you. If you decide clear lens extraction, is there an age range, Sarah? I know you touched on this a little bit, but how do you factor that in if somebody's going to be, left without the ability to accommodate at a specific age? Is there sort of an artificial cutoff in your head?
Yeah, I mean, I would say, again, I don't ever really do true clear lens extraction. And part of that is a reimbursement concern, but most people who fall into the category of needing their lens out do have some lenticular change, and I would call that a cataract. Mm-hmm. But I do try to avoid cataract surgery in people who are not presbyopic. I think the most important thing, if you have to proceed in someone who does have accommodation before surgery, is just to make sure you're managing their expectations. I think anyone can deal with presbyopia if they understand that it's a vision preserving surgery, but it certainly shouldn't be a post-operative surprise.
Okay. There was a question on whether there were slides on the Eagle trial. If you go to some of the links that I showed, and I'll show them before the end of this webinar, we have a lot of videos and a lot of lectures on various topics. Specifically, Eagle will be coming in the next maybe 2 to 6 weeks. Will be on the YouTube channel, and you can go to the YouTube channel and just see what else is there for now. But we're definitely going to put something up about Eagle and about ZAP. So here's a question that I get asked a lot by residents and fellows, and maybe Syril, you can answer first. How big should you make the PI hole? And then it says, I've done PI for many cases, but I still wonder, how can I be sure that the PI is patent already? So 2 questions really. 1, how big do you make it? Number 2, how do you know that it's patent?
So Malik, I come from a generation there was cases where I had to do surgical PI. So I had to take the patients into the operating room, and then you have to do a surgical PI. When you do a surgical PI, it's huge. You can actually see the ciliary bodies, zonules, everything from there. It's typically was done when I was a resident in 1990s. It was it's superior. Okay. And after that, I came here and I started working with a group of biomechanical engineers from University of Minnesota and other places. And then I actually wanted to see if the size of the PI actually does it make a difference, whether it's 200 microns or 400 microns, where exactly do you place it, whether it's extreme periphery or mid periphery. Would it actually, how will it affect the convex iris configuration, opening up the angles? Would it make a difference? No, not really. Mm-hmm. So even if it's very big or anything like that, something which has a constant slope, somewhere more than 200 microns is sufficient. I have already papers on this, probably you can see. Yeah, so, if it's, that's sufficient. The size, you don't have to go extremely big or causing all this. Even somewhere around more than 200 micron size is sufficient.
This one's aggressive. This isn't mine, by the way. This is a little bit more.
It's almost mid.
Right. This is a second pupil almost, but yeah. I use this in my LPI lecture to talk about leaving your signature behind and sort of what you want it to look like. Sarah, any thoughts on that?
They do end up like that, kind of mid-pupil in acute angle closure sometimes, because the pupil is so dilated. You're putting it as far out in the periphery as you think you can, and then once the angle closure is broken and the pupil comes down, you're often surprised that it's in the mid periphery. But I think you did that patient a huge favor, so you can't really worry about that.
Right. You try and do your best. And Sarah, you brought up a question to me by email about a couple of things around ZAP, and I started thinking about the questions. A lot of times we have these academic discussions about, kind of like what I have on this slide about what the pulse, how many pulses, what the energy is. What are some of the practical things that you have to think about when you're seeing a patient who's in angle closure? You have a first-year resident who's calling you. You show up to the emergency room. What are some of the practical things that don't necessarily come through academic papers or textbooks or, maybe the basic science series from the academy? Are there any pearls that you have for these acute cases where the patient's in pain?
Well, I think every patient in acute angle closure really, I'll say it with an asterisk, but I really mean it, regardless of comorbid medical status, has bought themselves 500 of Diamox, 500 milligrams of acetazolamide. In my book, I typically tell the residents to administer it right away. And then you can get the basic metabolic panel if you think it's medically indicated to determine whether they can have more carbonic anhydrase inhibitor. In some environments, mannitol is easier to get a hold of. I think you have to be a little bit careful in older patients with mannitol because of the risk of subarachnoid hemorrhage and other complications. But I think that you really want to try your hardest to hit them as soon as you make the diagnosis with medical therapy, because I think if you can break the angle closure medically, then you can typically wait 12 to 24 hours to do the LPI, and you will have a much easier time, and the patient will be much more comfortable. So I encourage the residents to really stand by, administer the aqueous suppressants, get some systemic meds on board, and do their very best to try to break it medically.
Syril, do you ever tap these patients? You ever try and tap the patients?
No.
Why not?
No, Malik. I used to do it long back, in an idea, the cornea can clear up a little bit, and then you can have much more clarity and visible, but unfortunately, what I've realized is it doesn't help that much for time. I've realized, the way the antechamber fills up, you're not actually benefiting the patient. So
how
within
about
an
for
hour.
how about for medication penetration? If you're trying to get the pressure down and the pressure is 60, one of the questions that came in was, do you try and tap the AC, get the pressure down so that you get better penetration of your topical medications?
That's a very good question, but I used to do it. All those things, tapping. Unfortunately, a year after I came here, everything is a group effort.
Mm-hmm.
I have a standby team in the ER who kind of take over, making the patient stable.
Mm-hmm.
Yeah, in terms of if they're nauseous, if I have to give them Diamox or mannitol, that's the IV line is the one that goes in first.
Mm-hmm.
And then I start the topical medication along, and then get them ready for the PI. Within a couple of hours, the PI is done. I never tap. I'm not sure about your experience. Most of the instances, getting the pressure down is the main thing we want to accomplish. Getting the topical medications by tapping it is far more riskier than giving them something IV, as Sarah was saying, with Diamox or mannitol. And that's much more faster way to bring down the pressure than pouring drops, especially in acute angle closure glaucoma patients.
So
I've tapped a few of these.
Yeah, go ahead, Sarah. Go ahead.
No, what were you going to go ahead? You were going to say something similar.
No, it's really similar. Yeah. So I think it actually, there's a theme to this discussion that we're having. It also depends on practice, and you just called it, Syril. You said when you moved to Mayo in Jacksonville that you have a team taking care of, which is great. From my standpoint, I think here, similar things, I'm in clinic. My clinic has a different feel to it. It's very mature, so I'm often in clinic seeing my routine patients. And if something comes in, it's coming in from the ER. Usually the residents have taken care of it to some degree. But when I'm outside of the country, which before COVID was becoming more and more a part of what I do, more traveling and more surgery abroad, if a patient comes in and I might not have all of the medications, I usually don't have all the medications that I have in the ER here. So tapping those patients, trying to get them more comfortable, trying to get the cornea to clear a little bit, and then trying to get the medications to soak in a little bit better, because there is science behind that it does actually, help. So in those cases, I will do that. And occasionally if a patient, comes into clinic directly instead of going into the ER, I will do that to get them comfortable. So it's that relief that allows you to do some of the other things that you need to do. And that's just, again, practice pattern, patient, all that stuff. Sarah, what were you going to say?
Oh, no, I was going to say the same thing. I agree completely. And I would just caution everyone, you do have to be extraordinarily careful, because these are phakic eyes with shallow anterior chambers, and you have made the situation suddenly much, much worse if you accidentally penetrate the anterior capsule with your needle. So do use extreme care if you're in this situation. I know there are people who do this sometimes under a surgical scope with a paracentesis blade. I typically do it at the slit lamp with a 27 gauge. And I think if you go inferiorly, you can try to use the iris, even a mid-dilated pupil, to try to protect you a little bit from the anterior capsule. And my pearl would be that if you are a dominant handed surgeon where you have a strong preference for doing a procedure with a specific hand, for me, I, in a tough situation like this, really prefer using my right hand. For a right eye, because the nose will be in your way, you can use a hemostat to bend your needle so that you can still enter the eye nasally with your dominant hand. So I would make sure you're doing whatever you need to do ergonomically to make it as easy and safe as you can.
Okay. All right. That makes a lot of sense. Let's see here. I'm going to go, some of these questions we've already answered in one way or another, so I'm kind of skipping over those. But Syril, it says rise of IOP after dilation of the pupil. What does that mean to you? How do you handle that? Do you think of it as an actionable thing that you should do? Should you do an LPI on that patient?
After dilation, especially in an angle closure patient?
Let's just say patient comes in, new to you, you check the pressure, it's 15, patient gets dilated, and you check the pressure for whatever reason, and now it's 30. How do you think of that?
I won't actually recommend. If it's an open angle patient, or like if it's an angle closure suspect, the modality of like the next step would be entirely different. Just because if you're dilating in an open angle patient, if it goes to 10, I won't do a PI. I would just rather manage them acutely with medication. And then PI is much more drastic for me, like in terms of acute rise of like 10, or I would go one step, treating them medically and then see if they respond. In a patient on another hand with hypermetrope, with a risky angle closure, and then been following up for angle closure and closed angle more than 180 degree, I would consider them once the IOP comes down sooner to do a PI.
Sarah, when you have a patient that you've done an LPI on, it's patent, you're comfortable that the LPI worked, how often do you see that patient back?
If they truly have no glaucoma, they were just a suspect, probably once a year. But if there's any inkling that they have glaucoma, I think it's a little bit different. I try to adhere pretty closely to the severe glaucoma every 3 to 4 months, moderate every 4 to 6, and mild every 6 to 12, depending on the scenario.
Okay. One question that we didn't get to, surprisingly, until now was a question that came in before the webinar started. It came into us yesterday, talking about angle surgery. So in these patients who have, chronic angle closure or any type of the angle closures that we've been talking about, would you consider, if you're doing cataract surgery, would you consider doing angle surgery at the same time? And Sarah, we can start with you.
Yeah, can I share my screen actually?
Oh yeah. Let me.
I happen to have a video of precisely this kind of thing.
All right. You should be able to access. There you go.
See here.
You may never give it back. You have control for the rest of the webinar
now. So this happens to be a patient. You can see her patent PI right here, and I've finished my cataract surgery. So now her angle is nicely open. And this is actually an excisional goniotomy with the Kahook blade, someone you may or may not have heard of, developed an instrument. But I actually love MIGS in these eyes. And sometimes that, for me, looks like excisional goniotomy. Once in a while, that's a GAT. I do some ECP in these eyes also. You can see that nice strip of TM. But I have found that these eyes are exquisitely sensitive to angle surgery in many cases, and obviously some of that benefit is from removing the lens, and it would be hard to quantify how much is from the lens removal versus how much is from the angle surgery. But I think it's intellectually satisfying to me that you're both opening an angle that was previously occluded and trying to reinvigorate its function. And I think in contrast to primary open angle glaucoma eyes where their angle is already open, so there's only so much you can do to resuscitate it. MIGS might get you a couple points, maybe a little bit more. Angle surgery and an angle closure eye together with cataract surgery can really, virtually, as we said earlier, almost be curative in a sense. So I love a MIGS in this scenario.
Okay, what do you think, Syril?
I totally agree. I don't know, like, have a few videos, but like, anyway, so the concept of minimally invasive glaucoma surgery, especially for angle closure, like, everything MIGS was based, the definition from everything like geared towards open angle glaucoma. But MIGS for angle closure, there are very few. And probably like what Sarah showed is extremely important for us to understand when you're doing a cataract surgery, and if you see anywhere a synechia, and if there are controversial reports about doing a goniosynoectasis, but something extra that you can do to actually go where Sarah is showing, where you're actually excising, or if wherever you can actually see the trabecular meshwork, if you're going to remove it, it's going to cause much more a different configuration of the angle. In here, it's kind of like once you go there, the root of the iris, once you do a goniotomy in this instances, the root of the iris falls much further. You're taking out the cataract, and you're also doing a goniosynoectasis or opening up the synechia where the iris is attached to the trabecular meshwork. The next point is actually doing something where like you're excising the trabecular meshwork is an extra step. Probably like, once there is some sort of like an attachment of iris into the trabecular meshwork, there is already a pathology that sets in. In open angle glaucoma, you can say type 3 collagen and all those things that gets into the trabecular meshwork. But in angle closure, it's an entirely different picture. It's almost like, fibrosis that's happening that's kind of like blocks the extra flow into the Schemm's canal. So you're kind of doing an extra step. It's far more fulfilling for doing this kind of MIGS in angle closure patients. Especially, you can see the EAGLE study itself, 9% are people who had some synechia. And if you are going to go one extra step, I would definitely recommend this.
Right.
And probably like there are 2 years data is already, I submitted it. It's a collaborative data with one of my colleagues from Vietnam. This is very, very fulfilling. And the percentage of IOP drop and the stability, it's almost like it's to a stay where like it's curable.
Right.
But one thing is, I would keep them on pilocarpine after this. So you're touching the iris, it's much more sticky compared to the open angle glaucoma. If I do this on an open angle patients, I don't usually keep them on pilocarpine, but this kind of patients where I touch the iris, I release it, I keep them for a little more longer, pilocarpine, or like I keep them on a little more steroids so that they don't develop a PAS immediately after, though you're increasing the size of the root of the iris here.
That was one of the questions, the pilocarpine use. So I'm glad you hit on that. Your 1 year data on excisional goniotomy in patients that are like this. I mean, this is whenever I talk about excisional goniotomy, it works in a wide range of patients, but this is one patient population where it's a home run, right? If you can take these patients and take the TM out, do goniosynoectasis, chronic angle closure, glaucoma patients tend to do really well. What were you going to say, Syril? Sorry.
That's something, there are a lot of data, controversial data that came in, especially like even from Singapore, Rahat Hussein's paper, which it's a prospective study. They looked into goniosynoectasis, how they accomplished to release the synechia from the angle and then going into the next step. It's all like, it's very different, but doing this way where you are kind of like accessing much more deeper structures and you're kind of like going into the actual pathology, so far the 2 year data, it really looks good for me.
Yeah.
And I think like it's better to kind of like push this to angle closure patient as a surgical option, especially when they undergo cataract extraction.
Let me, I'm going to ask a question, but Sarah, if you can give the screen to Syril so you can show some of your iridoplasty stuff. But let me ask a question as you put that slide on the screen. There's a question here about micropulse laser. So micropulse CPC or CPC, Sarah, in your case, do you see any role for it in angle closure?
I wouldn't say no as an absolute, but I mean, you're not really getting at the root of the problem. I tell patients that, the eye is a bit like a sink. You have the ciliary body, which is the faucet, and you have the drain, which is like the sink drain. And I think fundamentally the only way to get at angle closure is to open the drain. So I think whether there is a role for ciliary body ablation, I would say that is always as a supplement to addressing the drain problem fundamentally. I don't do micropulse much because I haven't found it to be wildly effective in my patient population. I do a fair amount of endocyclophotocoagulation, either in someone who's already pseudophakic or combined with cataract surgery. I do a fair some CPC in stage eyes.
Okay.
Malik, can I
yes.
say something on
Yes.
this? Because, because I do micropulse, and then I wanted to reflect something on it.
Mm-hmm.
As Sarah said, the first thing that we kind of like have to focus on, especially in angle closure patient, is to go diagnose where exactly the pathology is, and then go and attack it. Like whether you are doing a PI or you are going to do a lens extraction, goniosynostosis, or goniotomy. That's the first step. That will be far more beneficial. But if that doesn't help, like doing the next step as like before you're going to do a trab or placing a tube in those patients, micropulse may be an option.
Mm-hmm.
Because it's your concept here is not it's not like the actual CPC that we used to do before, where we are kind of ablating the ciliary body. Here, it's actually the different mechanism. There is a paper that got recently published from L.V. Prasada Institute, one of my colleagues from there, who actually did not like a micropulse, it's something like a internal ECP, where after she did the cataract surgery, she went inside. This is patients where they had thick brown iris with plateau iris configuration. She went ahead and did an ECP in this patient, and then she saw the configuration of the ciliary body completely changed. That's different, that's ECP. But in terms of micropulse, it's a different mechanism. But I would agree, like you have to go step by step. First, you have to go relieve the blockade and then think of other options.
Okay. Do you have a chance to show your iridoplasty? Yeah. And then maybe just walk us through, 5 minutes, maybe no more than that, just so we can get to more of the questions. It'd be great.
Yes.
I'll call you on it.
So, okay. I'm not going to I know this is a very controversial point. I never believed in a lot of things, like after I started doing a fellowship in New York City. And also, like I spent almost 8 years there doing UBMs until like I have to realize like what really happens at the angle after doing this argon laser peripheral iridoplasty. This is a totally different concept. People argue to an extent. Some people say that's useless, but I still say it has a role. It has a role. Like what we are talking about Eagle, and it's all about the kind of patients that you're going to pick up. Say if you have a patient who are in their 40s, young women, like in their brown iris, and when you do an indentation gonioscopy, you have a double lump sign, or when you do a PI, they still have a positional closure, and they're progressing with synechiae, and this is where the argon laser peripheral iridoplasty has a role. Yeah, I used to do it more often, but like if the patient is much more older, and if they're developing peripheral anterior synechiae with pressures of more than 50, I would just go with the lens extraction. I don't know whether I would call it like clear lens, but like that would be the next point. But I've seen patients who underwent iridoplasty where like I would do UBM just to see the peripheral iris configuration entirely changes. Even after doing a PI, the angles doesn't open up. And so these are the patients, young patients with the plateau iris configuration who have some benefit. As you can see, this is much more longer, the argon laser that you are going to use. And the power is like around 200 to 500. And the spot size is like almost like I give like 400 to 500. So I use an Abram lens, and then you're trying to place the burns to the extreme periphery. You go to the extreme periphery, almost like 2 burns in every clock hour. You give almost like 6 in each quadrant. And then what you're trying to accomplish is, it's almost like squishing a Wonder Bread. The burns are like so long, it goes to the extreme periphery. And wherever you're not able to see the angle structure and you place it, it kind of opens up a little bit. So I don't know like how this helps. Like over time, it's basically, as we are speaking about releasing the synechiae or mechanically doing something to open up. It's for us, like the first step is angle closure is an anatomical disease. but there are certain people who might be benefited in it. So that is the concept. People are going to like fight, saying like it has no role in it. And like, people who have done it, they say it has a role in it. So it's all individualized. I'm not going to argue anywhere, but this is something, I don't know whether this might go out of, like our practice, like the way they're like, other options are available for us. But this is something I've tried and I've done, and I've seen the angles opening up in certain group of patients.
Yeah.
So I will,
Does Sarah want to argue?
No, I don't doubt that it has a role. I just haven't really met a patient yet that I think needed it. I think in my practice thus far, at least, most of these patients have either been okay with their LPI or have benefited from lens extraction.
So the question now is, you have Sarah, like you have a 40-year-old patient, a female with, onset of presbyopia, and like she has thick brown iris, and you do a PI. Probably like when we are like resident, we used to discuss something about plateau iris syndrome, plateau iris configuration. Plateau iris syndrome is someone, even when you do a PI, the angles doesn't open up, right?
I think,
so,
sorry, I think I'm having earphone issues, but I
so
think
if
that
yeah. Can you hear us okay? Oh, she might be muted.
Yeah, like, okay.
Cyril,
So,
do you have power to mute her? Is that what you just did?
No,
I think you're back, Sarah. You're back.
Okay, I think it's my earbuds are dying, but
okay. Okay. Let's just move on. It sounds like there was look, it's actually very similar to what we discussed with Eagle and Zap and some of the others, right? So there is that potential that some patients might benefit. It depends on your practice. Your practice in Jacksonville might be very different than my practice in Denver. And I think that's kind of the theme, right? That we have to look at our own practices.
It's also like the age group of the patient. And like, if they have a very clear lens, and if you see when you do a UBM on patients, if you see the configuration of the ciliary body is entirely different, you're kind of like mechanically opening up so that you prevent the progression of, angle closure in these patients. Before I take them to a clear lens extraction, I would try in young patients like this.
Okay, there's a question here that, I don't want it to get into a slippery slope here, but it's come up a couple of times by different people here. What is your opinion about iris sponginess mechanism in angle closure? This is a very academic thing that's discussed in the literature. And maybe Cyril, primary iris stromal pathology and its role in angle closure. How do you think of that? I've had discussions about this with Deepak Edward formerly from KCUSH, now back in Chicago, and just reading papers about it to see what mechanism it might actually play. How do you think about iris sponginess?
It's probably like you remember, like when Harry Quigley gave a talk, Jackson Memorial Lecture. The concept is iris is a sponge for angle closure. Whatever the pathology that's happening, even if it's an expansion of the choroid, the fluid that's kind of like it's from the posterior compartment is kind of like transmitted to the iris, and then it's kind of like expanding, and that's what it causes the angle closure.
Right.
So I've done a study about like if you take the iris in an enucleated eye, if you take the iris in an enucleated eye and put it in a petri dish, reverse it, it will always go convex. This is published in IOVS. So the concept of blood flow, where it acts like a sponge to increase the thickness, and then where it becomes much more convex, it's not refuted. Like it's proven. It's a biomechanical study that we did, but you take the iris, a dead enucleated eye, and then do a complete excision of the iris and put it in the petri dish. It will go like a convex iris. If you reverse it, it will go like this, irrespective of the flow of the fluid. So the concept where the fluid iris is acting as a sponge, making stromal expansion with giving rise to a convex iris configuration. I have to do more studies on it to understand that concept. But my understanding at this time, whatever that's happening in the choroid, if it's having an impact on the ciliary body and the iris, I need more studies, but I don't remember anything that can refute it.
Okay, maybe throw the screen back to me here.
Yeah.
And then I have a question for both of you that has come up again by two different people about laser trabeculoplasty. So let's say you've done the LPI and, angle opens up, patient has higher pressure. In those patients, do you consider doing SLT or ALT, Sarah?
Yeah, in my chart notes, this says sequential LPI SLT typically. I would say it's not the norm, but it happens some in my practice. I think the caveat, more so with ALT than with SLT, but really with both, is that you do need to make sure the angle has sufficiently opened, because you can cause pretty impressive PAS if the angle is not sufficiently open to support SLT. But I do think there is a role for sequential laser treatment, and it can work quite nicely.
What do you think, I agree. Yeah, I agree. It's exactly the concept of what we are doing in terms of goniotomy and goniosynostosis, where we are thinking the distal collector channels, even when it's open, it's still functional. Actually, there is a paper that was published by Yaniv Barkana from Israel, looking into SLT as an offer, that you do it in angle closure patients, and it's very effective. And I would say patients who underwent a PI and the angles opened up, and if you don't see much more pigment or a peripheral anterior, I would definitely offer this, and it's proven.
Okay. Sarah, would you ever do a premium lens multifocal in a patient that you're going in to operate on like this, who, let's say they don't have any sign of glaucoma versus if they have some signs of glaucoma? How do you think of that?
I don't do that many premium lenses, so I am not the world's best authority on this topic. I will say that hyperopes tend to be the easiest to please with multifocals. You can just almost do no wrong. And so I think it does come up now and again that someone who had an occludable angle but truly has no glaucoma, who is hyperopic, is interested in a multifocal, and I do not deny them that opportunity. But I have an absolute no tolerance policy for multifocals in anyone with glaucomatous disease, and I very often steer patients away from them regardless.
What do you think, Syril?
Why not? So if you have patients, like my concept of what to offer to this patient's entirely changed, because it all depends on your patient population. You would argue, because I have patients who will come who want to do things the next day. Yesterday I did 6 femtos. People with you suspect without any angle closure, pigmentation or a peripheral anterior, you don't have to do a goniosynostosis in them. Hypermetrope, femto. I did femtos yesterday on them. My colleague actually does enhanced depth, ED IOLs, and then he also does multifocals. Mm-hmm. If the patient has glaucoma, then it's a different concept. Yeah. I don't recommend that. But patients who are hypermetrope, who are suspects, and optic nerves is healthy, baseline everything is fine, young patients, and if they want, I just tell them everything, the problems that they're facing right now. And I do have a huge chunk, probably I don't do that many femtos, probably 15 to 20 femtos a month, but most of them hypermetropes, angle closure suspects, and they take premium lenses.
So you have a unique practice, Syril, and 15 to 20 femtos a month is certainly unique amongst glaucoma specialists, not just in the US, but around the world. And you and I have talked about this. Your practice is very high volume surgically and very unique, and you're adventurous and you're a great surgeon. And I do think that your view is a little bit different. One of the challenges for me, all of these debates that we've had at Academy, AGS, international meetings, where you have one surgeon saying, I'll never put in a multifocal, and the other surgeon saying, of course you have to put in a multifocal. I think, I was always on the side of maybe let's not use multifocals in these patients who are likely to progress to visual field defects, and it might actually compromise. But now that debate is different because we have different lenses that are emerging on the international market. Just looking at different ways to get enhanced depth of field. There's a new lens that just made its way to Canada. Hopefully it'll come into the US soon, Vivity from Alcon. not putting in a plug, no financial interest at all in that. But, it's a different mechanism for getting depth of focus. And we have to start asking these questions more and more. Are we doing our patients a disservice by not giving them a premium lens if we're constantly thinking about a restore? Let's use another Alcon product that, on the other side of the debate, maybe don't use that because of the way the optics might work. In my practice, I don't do multifocals. We do torics. I'm certainly not a heavy user of torics like some of my other partners, but I think that's the right thing to do, at least to be offered to the patient. And these debates will continue because the better we get at treating the glaucoma part and we get more comfortable with that, the more we're going to start thinking about refractive and making sure that they can see better and better. Looking through the questions, we've answered the majority of the questions. We're getting some repeat questions that we've already touched on. So I'm gonna start closing the webinar here just by saying a couple of things. We can continue to answer questions through, please go to the CyberSight website. You're going to see this lecture posted. There's a system for talking to mentors on the Orbis website where you can ask questions. I'm on that, so you can certainly reach out to me and ask me some questions. This YouTube link, it'll take you to a channel where I just populate all of the lectures, and you can ask questions within that. And if there's anything interesting for Syril or Sarah, I'll get them involved in answering some of those questions as well, because there might be some stuff that you didn't want to ask on the Q&A or before the meeting. And please keep asking these questions. I'd also personally love some feedback on the point-to-point format. We did this for 2 hours. Maybe that could be maybe a little bit too long for some, maybe not long enough for others. I'd love to hear through Orbis, just let them know the feedback on the length and the panel discussion in the way that we did that. We can certainly modify it. The next point-to-point is going to be December 17th. It's going to be surgical. We're going to talk about tubes. And I expect both Sarah and Syril to email in some questions. I won't put you on the spot to participate, but please, send some questions in. And it's going to be heavily surgical, some videos, and just talking about our techniques for different glaucoma drainage devices and pearls for practice. And then I'll close off by saying thank you. Sarah, I know you're busy. I know that, from a practice standpoint, it's not easy to take a morning off. And I don't think I invited you. I pretty much just said, please, I begged you more. So thanks for doing it. And Syril, I know you had to move your clinic around as well. And I know how backed up you are because of COVID issues. So I thank you very much to both of you. I know the audience is sincerely thankful for your time as well. And I owe you both one, so I can't say no to whatever you invite me to next. So thank you again to Orbis, to CyberSight, to Lawrence for helping us put this together, and to the audience, thank you for taking the time. And please do reach out with questions and comments, and we'll see you back here, point-to-point, December 17th. Thank you.
Thank you, Malik. Thank you, Sarah.
Thanks, everyone. Be safe. Take care.
Yeah, bye-bye.